Hello, my name's Dr. Christopher Lewis-Lloyd, and welcome to this week's Journal Club. I'm going to be presenting a paper entitled The Risk of Postoperative Venous Thromboembolism After Surgery for Colorectal Malignancy, Systematic Review and Meta-Analysis. This is an adapted presentation from the University of Nottingham Sue Watson Oral Presentation Prize 2021. So I was lucky enough to be part of this study, and it was recently published in the Journal of Diseases of the Colon and Rectum back in January 2021. So we're going to go through a bit about the why, how, and what was found within the study and what this all means. And hopefully by the end, you'll have an understanding of the importance of VTE, or venous thromboembolism, after cancer surgery, a bit about the knowledge of the burden of colorectal cancer and what impact VTE has after its surgery. So let's begin. So within the UK and internationally, colorectal cancer is the second highest cancer killer of all the cancers, with just under 1 million deaths per year worldwide. This equates to roughly 1 in 25 people in the UK in their lifetimes developing colorectal cancer. And unfortunately, just over 1 in 100 of us within the UK will die from colorectal cancer disease. So this just gives a brief background as to the importance of the burden of colorectal cancer within the UK. Then we have venous thromboembolism, or VTE for short. This is essentially venous blood clots within the body. And this can occur because of disruption of the hemodynamic changes within vessels, hypercoagulability, or vessel endothelial dysfunction, aka Virchow's triad. And it can occur in the lungs, which can be fatal, which are known as pulmonary embolisms, or can occur in the legs or other extremities known as deep vein thromboses. It's important to note that VTE significantly increases the mortality of patients, particularly postoperatively, with the 30-day mortality having had a VTE post-op compared to those who don't is roughly a 4-fold increase. However, we can prevent and even treat VTE by the use of low molecular weight heparins, such as Clexane, and we have regimens for this, and particularly in cancer surgery, it's recommended internationally that we use an extended period of prophylaxis for 28 days. So fundamentally, surgical resection of colorectal cancer provides a potentially curative management plan. However, VTE is a major postoperative complication, with large bowel resections having one of the highest risks of postoperative venous thromboembolism of any abdominal operation. Yet VTE is considered an avoidable complication with appropriate use of chemo and mechanical VTE prophylaxis that is relatively cheap compared to the costly impact that VTE can have as a complication, particularly after surgery for colorectal cancer, and itself can be fatal. So, we set out to define the instance of VTE post-colorectal cancer resection, and therefore how this compares to other general surgical operations, assess the rate of VTE at different lengths of follow-up, and what this means for extended VTE prophylaxis use, and how does the rate of VTE by global region, as well as the use of minimally invasive surgery and operation site vary? And overall, how does this affect postoperative VTE guidance? We searched 5 major online databases, including the Ovid Medline and Embase databases, as well as the Cochrane Library. Only randomized control trials and population-based database registry cohort studies were included, and we adhered to the PRISMA and Moose guidelines for reporting systematic reviews. Inclusion criteria consisted of patients post-colorectal cancer resection aged 18 years or above, and those excluded were patients undergoing benign or completely endoscopic surgery, and those without having cancer of resection, or if VTE or a combination of PE and DVT outcomes were not available. Where possible, only symptomatic VTE was counted, and data was extracted to include 30 and 90-day incident rates of symptomatic VTE following colorectal cancer surgery, expressed as per 1,000 person years. From just under 6,500 titles collected, post-screening and deduplication went to just under 200 full text analysed. And this ultimately led to 28 full texts being available, with 10 of these being randomized control trials and 18 were population-based cohorts. Due to a large amount of follow-up length heterogeneity in the randomized control trials, only the population cohorts were available for full meta-analysis. So from just over 500,000 patients analysed, the 1 month rate was 195 per 1,000 person years, with a frequency of just under 2%. And the 3 month rate was 91 per 1,000 person years, with a frequency of just under 2.5%. To try and put that into some context, the updated Cochrane systematic review of this subject that reported a similar 30-day symptomatic VTE rate of 117 per 1,000 person years in those without extended prophylaxis use in abdominal pelvic cancer surgery operations. So that was the cutoff for the benefit use of using extended VTE prophylaxis in cancer resections. We also examined by United Nations Geoscheme Area, and we stratified the rates to look further by different global regions. And what we found was that at the 1 month within Americas, the rate was significantly higher than in the rest of the world, particularly Europe and in Asia. And this was mirrored when we examined 3 month rates, yet again with the VT rates within North American studies being significantly higher than in Europe and Oceania. So this is some forest plots to help illustrate that in more detail, showing that at the 1 month mark, VT rates within North American population-based studies were significantly higher overall compared to international European studies. This was mirrored at the 3 month mark. So what does this all mean? Well, the incidence of VTE following colorectal cancer resection is high. Compared to other general surgical procedures previously reported, such as inguinal hernia repairs, cholecystectomies, and appendicectomies that have VTE rates maximum at 30 days around 30 to 40 per 1,000 person years, compared to 195. We know that the incident rate remains high more than 1 month after surgery. Although the 90-day rate is less than the 30-day rate, it is not too dissimilar from that 30-day rate calculated from the previous Cochrane systematic review at 117 per 1,000 person years. This may suggest an argument for extending VT prophylaxis for a 3 month period following surgery. However, additional contributing factors, including chemotherapy, itself an independent risk factor for VTE, may have affected the absolute rates of VTE following colorectal cancer resection. Importantly, there is a clear disparity between the incidence of VTE post-colorectal cancer surgery by global region. So we speculated why this might be. So, are the USA worse than Europe in terms of their VTE rates and quality of care? Well, this could be due to obesity, a well-known independent VTE risk factor, and with the prevalence of obesity significantly higher in the US than in Europe, according to the World World Health Organization, the difference in VTE rates may be attributable to demographic factors. Another explanation may stem from the global differences in healthcare systems, with high-cost private insurance systems within the United States, compared to subsidized or even free national health systems in Europe and the UK. Recent US database studies have reported that only 1.5 to 4% of patients undergoing colorectal cancer surgery collect their VT prophylaxis on discharge due to health cost concerns. Another reason may stem from adherence to guidelines. A national UK survey in colorectal surgery demonstrated over 95% of responders followed national prophylaxis guidelines. However, recent North American studies found that only between 18 to 70% of patients who underwent colectomy did not receive VT prophylaxis as per national guidance. However, just because VTE rates are higher in the US may not necessarily mean North America has reduced quality of care. In the US, reimbursement directives with a focus on VTE as a preventable outcome have resulted in increased active surveillance of postoperative patients receiving VT prophylaxis and an increase in incidental VTE findings on CT scanning due to its increased use and improving diagnostic yield. This surveillance bias may affect the perceived incidence of VTE because national databases are unable to identify incidental VTE encoding. In America, studies have shown hospitals with higher VTE surveillance rates have higher inpatient but not reduced post-discharge VTE rates, and hospitals with higher quality scores have higher VTE prophylaxis rates but worse VTE rates that are associated with increasing hospital VTE imaging. In essence, the more you look, the more you find, and therefore the more you can treat. And this, coupled with recent findings that cancer patients developing either symptomatic or asymptomatic incidental VTE have equivocal morbidity and mortality outcomes, highlighting proper treatment and identification of incidental VTE is of more importance than previously perceived. This may suggest a reason for the observed differences in VTE rates between regions that does not assume higher rates imply a reduced quality of care. However, there are a few limitations to this study. The rates provided were derived from multiple populations with a wide range of demographic and operative variables, and so give an overall incidence of postoperative VTE in colorectal cancer surgery. Rates for specific populations, those deemed at high risk of VTE, for example, the elderly or those with advanced stage disease, were unable to be calculated. Therefore, the results cannot be generalized to individual subgroups of interest. The great differences observed within the follow-up length and how VTE was assessed as an outcome after colorectal cancer surgery between the randomized controlled trials significantly affected the calculated rates of postoperative VTE, meaning they could not be used within the meta-analysis. Within population-based cohorts, it was not possible to separate symptomatic VTE and incidental VTE diagnosed on screening due to the nature in which VTE outcomes were coded within the databases utilized by the studies. However, most VTEs within the database cohorts are likely to be symptomatic, as there were no specific VTE screening programs used within each cohort study. Many studies within the quantitative synthesis spanned long time intervals, where changes in surgical care and VTE prevention guidance changed. This could have affected the results of this study. However, on analysis by United Nations Geoscheme Area, there were no significant trends observed between the studies by increasing year of study publication date. So, in summary, the incidence of VTE following colorectal cancer resection is high, with a persistent risk lasting more than 1 month after surgery, suggesting extended prophylaxis may still be of benefit in the prevention of VTE. Globally, the regional rates of VTE differ in the surgical population, and this variation may be determined by differences in both demographic and clinical practice factors, such as surveillance protocols observed between populations. To further interpret the international comparisons of postoperative VTE requires further understanding of the effect differences in surveillance practices and therefore incidental VTE diagnosis have on relative patient risk, meaning more robust population studies worldwide are required to determine valid regional VTE incident rates. This research can help form contemporary evidence-based guidelines in respect to the prevention of VTE after cancer surgery, as the rates are likely not too dissimilar from other abdominopelvic cancers. Overall, the global variation suggests the rate of VTE following surgery should be assessed at a regional level when determining recommendations and guidance on its prevention. Therefore, when comparing rates of postoperative VTE against a regional standard, it is necessary to acknowledge that the rate observed may be influenced by the factors previously mentioned and what this means in terms of quality of care. Thank you for listening.